Good afternoon, everyone. I'm Joanne Starks of SEDL, or CEDL, in Austin, Texas, and I will be moderating today's webcast entitled Knowledge Translation from Research to Vocational Rehabilitation Service Delivery. The webcast is offered through the Center on Knowledge Translation for Disability and Rehabilitation Research, KTDRR, which is funded by the National Institute on Disability and Rehabilitation Research. I also want to thank my colleague Ann Williams for her logistical and technical support for today's webcast. Before we introduce today's speakers, I'd like to turn to Cindy Kai to give an overview of today's webcast and how this webcast, the first in the series, fits into a broader context for knowledge translation from rehabilitation research to vocational rehabilitation service delivery. Cindy?
Thank you so much, Joanne. Hi, I am Cindy Kai from the American Institute for Research, or AIR. I manage the sub-grant between AIR and CEDL to develop a series of webcasts and to establish a community of practice to help promote the understanding and use of evidence-based practices in the field of vocational rehabilitation. My colleagues Jerry Mendez and Mahi McGrath from AIR have been instrumental in the development of the webcast and the related community practice. The key audiences of our webcast and the community of practice are vocational rehabilitation researchers, practitioners, policymakers, and consumers. Today, we're launching the first webcast, Knowledge Translation from Research to Vocational Rehabilitation Service Delivery. As you know, vocational rehabilitation or VR professionals are facing increasing challenges to increase employment outcomes for people with disabilities in this tough economic environment. To address these challenges requires the use of evidence-based practices that are likely to lead to successful employment outcomes. Practice guidelines are a strategy used in systems similar to vocational rehabilitation to help identify and implement evidence-based practices. In this webcast, we will discuss what practice guidelines are and how they are developed, particularly in rehabilitation medicine, the extent to which evidence influences rehabilitation education. Can practice guidelines be relevant to VR professionals to implement evidence-based practices? How our discussion today can inform the current state of research and its application to the state and federal VR programs and the services provided by VR agencies. And finally, what would it take from an operational perspective for practice guidelines to be applicable to the VR service delivery setting? For this webcast, we bring in three views from a rehabilitation researcher, a VR educator, and a VR practitioner. Now I'm going to turn to Joanne, who will introduce our speakers today.
Thank you, Cindy. It is my pleasure to introduce our colleagues who have agreed to engage in a discussion this afternoon around the issues that Cindy has identified on evidence-based practice in VR services. Our first presenter will be Dr. Tamara Bushnick, who is Associate Professor of Rehabilitation Medicine and Director of Research at the Rusk Institute of Rehabilitation Medicine at NYU's Langone Medical Center. She is currently Principal Investigator of two NIDER-funded projects, a traumatic brain injury model systems, and a field-initiated project on treatments and effectiveness of prosthetic systems. Before joining the Rusk Institute, she served as Director of Rehabilitation Research at the Santa Clara Valley Medical Center from 1998 to 2009. Our next presenter will be Dr. Robert Stensrud, a Professor of Education from Drake University in Des Moines, Iowa. He has been a faculty member at Drake since 1988 and teaches courses in counselor education, rehabilitation counseling, and mental health counseling. Dr. Stensrud has also served as Director of Drake's National Rehabilitation Institute. Our third presenter today will be Mr. John Connolly from the Council of State Administrators of Vocational Rehabilitation, or CSAVR. He joined CSAVR in 2009, where he has primary responsibility for research and grant projects. He has a 30-plus year career in vocational rehabilitation. He filled many important roles at the Ohio Rehabilitation Services Commission from 1980 to 2009, including General Counsel, Deputy Director, and Executive Director. I want to thank each of you for agreeing to spend some time with us this afternoon to examine this important issue from a variety of perspectives. We will start off next with Dr. Bushnick, who will discuss the first of our 10 discussion points. Tamara?
Thank you, Joanne. Before I start with the first 3 points that we are going to be discussing, I'd just like to say that I am indeed a rehabilitation researcher and not a clinician, and have never been a clinician, as well as I will be talking about some of the work that the American Congress of Rehabilitation Medicine has done in order to produce clinical practice guidelines, and as a disclosure, I'm the current president of ACRM, which is why they're going to feature in this discussion. So I was asked to start and create the framework for talking about clinical practice guidelines and how they may be used both in rehabilitation medicine as well as hopefully in vocational rehab as well. So the first question was, what are practice guidelines? And clinical practice guidelines, as you can see on the slide, were first defined in 1990 as systematically developed statements to assist practitioners and patient decisions about appropriate health care for specific circumstances. And I think this is an important point, that the clinical practice guidelines in a lot of cases are aimed or focused on practitioners, but there are some agencies that have done quite a bit of work to try to create patient clinical practice guidelines that patients can understand and perhaps take to their service provider in order to assist with their care. What has also happened since 1990 in the year 2000 was the concept of evidence-based medicine. And this builds on the clinical practice guidelines, but includes not only integrating best research evidence, but also clinical expertise and patient values. And I'm sure most of us in the field are very aware of the push towards evidence-based medicine, and clinical practice guidelines are one of the most important ways in which we can start to build the evidence that is required for rehabilitation medicine. So how are they used in the medical field and in rehabilitation medicine? Well, they can serve a wide variety of uses, and some of them are listed here. The first and most obvious is that the practice guideline would describe appropriate care based on the best available scientific evidence and broad consensus in the field among experts. They also serve to reduce inappropriate variation in practice, and this is something that's very important for rehabilitation medicine. We have tended to lag behind the rest of the medical fields in developing evidence-based medicine and developing clinical practice guidelines. I'm sure most people who are listening to or participating in this webcast are familiar with the term called the black box of rehab. What exactly happens during a physical therapy session with a person who has who's had a stroke, versus what happens in a physical therapy session with a person who has a spinal cord injury. And we're just starting to try to look at exactly what is going on and what are the best practices so that clinical practice guidelines can be created. The third point is that they provide a more rational basis for referral. So where do we go next? What services should be prescribed once a person reaches a certain level? They provide a focus for continuing education, both for practitioners, so therapists and allied healthcare professionals, as well as the family of the individual receiving the rehab services, and the person with the disability themselves. It does promote efficient use of resources. There is a consistency following a clinical practice guideline It becomes reasonably clear what sort of equipment is required, the amount of time that is required for administering the therapy. It acts as a focus for quality control, which is also incredibly important as, again, rehab is becoming more widespread, and there are institutions that may not have been well experienced in providing rehabilitation for individuals, and the clinical practice guidelines can help to make sure or help to ensure that the type of rehabilitation that is being delivered reaches a certain quality. And then, and then from sort of my perspective as a researcher, in creating a clinical practice guideline, and particularly in rehabilitation, it does highlight the shortcomings of the existing literature and suggest appropriate future research. And that has been something that has been somewhat daunting in the rehabilitation field with respect to creating clinical practice guidelines or conducting systematic reviews, which could then be translated into clinical practice guidelines, in that in a lot of cases there just isn't enough evidence in the literature to firmly recommend a certain guideline. And so in a lot of cases there is a lot of research and that still needs to be done. So how are they used in rehabilitation medicine? On this particular slide, what I have is just some examples of organizations that have worked on creating clinical practice guidelines and practice standards. The largest one and probably the best known is CARF, which is the accrediting organization for rehabilitation. And in fact, CARF not only creates standards and uses guidelines for inpatient rehabilitation, but they have a multitude of locales and times of life that a person is progressing through in which they provide standards. For example, subacute nursing facilities, as an example of a lifetime issue, aging. What are some of the standards around individuals who are aging? An interesting one that I discovered was from Scotland, the management of patients with stroke, identification and management of dysphagia, a national clinical guideline. So that is a medical clinical practice guideline. The American Congress of Rehabilitation Medicine, the Brain Injury Interdisciplinary Special Interest Group, has a task force on disorders of consciousness, and they published a guideline on assessment scales for disorders of consciousness, evidence-based recommendations for clinical practice and research. So that crosses both clinical practice, in which what they recommend the appropriate measures that should be used to assess disorders of consciousness, but also point out in that guideline where additional research needs to occur. And then as an example outside of the acquired brain injury realm, the Consortium for Spinal Cord Medicine Clinical Practice Guidelines that have been created by the Paralyzed Veterans Association, and I have the website there, they have published a long series of clinical practice guidelines for spinal cord injury, and they have also published practice guidelines for consumers as well. So this is an example of where there's usually a professional clinical practice guideline and a complementary guideline and information targeted to the individual and the individual's family. Now on to point number 2. How are these guidelines developed, and by what process, by which entities, and who is involved in this process? Now I've already talked about this a little bit in the previous slide, but a very good way to create a practice guideline is to undergo a systematic review of a topic. What this does, there are templates that are available. The most well-known is the Cochrane collaboration, where they have a very manualized way in which to do a systematic review of a particular topic. They also have a very large library of systematic reviews that have been conducted under the auspices of the Cochrane collaboration. What the systematic review does is it, again, points out where there is adequate evidence, it rates the evidence, and then there is usually a recommendation that comes out from the evidence. If there isn't enough information, there might be a practice recommendation, not a guideline. And if there's no evidence at all, it will simply state that this is an area that needs to be further investigated. The CARF method, they use systematic reviews as well, but they also rely on input from providers, consumers, payers, and other experts from around the world. So it's a very intense process to try and create the practice guidelines that CARF recommends, and that if you, as a rehab facility, or are involved in rehab and wish to be accredited by CARF, you need to be able to follow these guidelines. And it is definitely from around the world. And what is nice about that is that as CARF is in many different countries now, we're starting to see a standardization of the care that's being provided for individuals who are undergoing rehabilitation. Then professional organizations such as ACRM, the American Spinal Injury Association Asia, the Paralyzed Veterans Organization, Paralyzed Veterans of America Organization, and the American Stroke Association also have task forces that put together practice guidelines, and these task forces also seek the input of not only professionals, but also consumers, payers, and other experts. One last thing I'd like to say before I move on to the next slide is that with CARF, and certainly with all practice guidelines, and this should be a best practice, CARF certainly does this. They revisit their guidelines on a standard timeline and revise them. So in fact, almost every year there are updates to guidelines as more information becomes available. And that should certainly be something that occurs with all practice guidelines as the field advances, new techniques are implemented, and so there should be an updating of practice guidelines. And finally, point number 3, some examples of practice guidelines. I've talked again a little bit about this. One interesting one that I did just find, it was, and is particularly apropos for this webinar, is the 2012 publication in Journal of Occupational Rehabilitation, looking at vocational evaluation after traumatic brain injury. And what these authors did was, indeed, they conducted a systematic review, and they came up with a set of guidelines for evaluating an individual for vocational rehabilitation. Now, they are not attempting to create a practice guideline for delivering vocational rehab services, but simply trying to systematize how a person should be evaluated for vocational rehabilitation services. Again, CARF, the Scottish group, American Congress of Rehabilitation Medicine, and the Consortium for Spinal Cord Medicine Clinical Practice Guidelines, as I mentioned. There's also a very nice website if you're interested in determining if there is a clinical practice guideline available for the particular topic that you're interested in. And it has been created by the Agency for Healthcare Research and Quality, or AHRQ, and it's called the National Guideline Clearinghouse. It's available online and is searchable, where they are trying to pull together all clinical practice guidelines, not necessarily specifically for rehab, of course, but across all of healthcare. But it is a very valuable resource for determining whether a guideline is available and is suitable for implementation in whatever setting care is being delivered. And with that, I believe I will stop. And Joanne?
Yes, thank you very much, Tamara. We're going to move on now. Our next presenter is Dr. Stensrud, and he will pick up at discussion point number 4. Bob?
Hi, my name is Bob Stensrud. I teach at Drake University in the Rehab Counseling Program. Before coming to Drake, I was at St. Louis University Medical Center in their Hospital Administration Program. Well, there we were providing education and consulting right in the middle of healthcare's transformation to diagnosis-related groups and peer review organizations, DRGs and PROs. And so I got to watch what happens when you begin evaluating people and their performance on the basis of what they should not be doing as opposed to what they should be doing. And with the implementation of things like the Institute for Healthcare Improvement, we really watched what positive partnerships between providers and researchers could do to improve practice guidelines. We've tried to work with that at Drake in terms of rehabilitation education, which is the topic that I'm going to cover today. In terms of evidence-based practice, you need to understand that it's a research methodology in which large populations are randomly assigned to an experimental and a control group. So researchers can look for significance between the groups on a specific factor. The best example is drug research, where they give a drug to one group of people and a placebo to the other, and then they determine whether the drug has more positive benefits than the placebo. In terms of broad practice guidelines, this is useful, but we still see there are limitations when we get to the rich practice settings of counselors. And again, very similar to what Tamara presented, here's an example. We have correlations between heart attacks and high cholesterol. So people with higher cholesterol are more likely to get heart attacks. We also have research that prescribing statins reduces cholesterol. Therefore, a broad practice guideline would be people with high cholesterol should be put on statins. That will reduce their cholesterol and thus reduce their risk of heart attack. When applied in the rich practice settings of individual physicians, however, this is only a suggestion. Physicians who will know more about an individual patient will decide whether to prescribe the drug, how much to prescribe, how they will monitor the effects and side effects of the drug, and then whether it's worth it to the patient to continue or discontinue that medication. So here's the concern that we hit with evidence-based practices. They give us broad guidelines, but in terms of what it means for specific clinical practice guidelines, we need a different perspective. Methodologically, we know that evidence-based practices on average cannot tell an individual practitioner what is the best practice with a specific patient. Best practice research, on the other hand, is less empirically sound, but often more practical. Best practice research is more likely to look at what works in practice and then use the outcomes from those data to evaluate the validity of the claim. A person may try a specific intervention in their setting, they find it works, and they share this with other people. As more people share it, they say, this is a best practice, this is something you should consider. If a practice such as motivational interviewing is found to work in the field to improve VR participants' development and adherence with an individualized plan for an employment, an IPE, and evidence can be found that in the quality of case closures, we can consider this a best practice. Evidence-based practices can be best practices, such as motivational interviewing, but best practices are not supported by the sound research design. They can't tell us under what conditions they are and are not appropriate. So we still only have broad practice guidelines. If we want to reach an individual counselor to say, what do you do in this situation with this specific participant, we've got to find a different way to educate our students and prepare our counselors. A difference between evidence-based practices, best practices, tends to be in the area of field-based research on the rich practice settings that rehab counselors deal with. We need to convert these best practices and the evidence-based practices into situational specific guidelines. In terms of research, we call this an aptitude treatment interaction research. Here what we look at is, given the characteristics of the participant, given the participant's environment, job goals, labor market, and so on, what is the best thing to do to assist this participant in their IPE planning and supporting them as they carry out the plan. This approach, if we look at it from an ATI, Aptitude Treatment and Interaction perspective, provides informed clinical practice guidelines rather than just informs practice. And that becomes one of the major issues that we are most concerned about. There we go. So with point 5, I use the example of employment models. We have some substantial research behind supported employment. Supported employment can be considered an evidence-based practice, while other employment practices are not at the same level of research evidence. Client-centered placement, demand-side placement, customized employment, and contracted placement are all examples of other employment models that have some degree of empirical support. In the rich practice setting of the VR counseling office, choosing supported employment simply because it's an evidence-based practice doesn't support either participant informed choice or counselor judgment. To support the counselor in this rich practice setting, counselors need to understand the different employment models that work with participants and determine which alternative is best in this specific case. So the decision models that they use are key to them deciding not only what is the evidence-based practice to use, but given their case, what do they know about all the research, and how do they draw from the research to make the best choice in that specific setting. This is basically the approach that we use at Drake. And what we do at Drake is we have a system. We're a core accredited program. CORE is the Council on Rehabilitation Education. They accredit all rehab counseling programs around the country, and their emphasis very much is on developing skilled counselors who can go out and make sound clinical judgments in rich practice settings, practices that are very complex and need careful thought when deciding what to do. So the way we will do this at Drake is we have several introductory classes that students take, followed by a supervised practical experience. Then they take more classes, and that's followed by another supervised practical experience. In this case, our practicum, the students are actually supervised by a local VR supervisor. So they're not only supervised in terms of their counseling skills, but in the relevance of those counseling skills and the decisions they make to the way VR counselors practice. We also have a fieldwork class where they go out and work with a specific client on providing placement assistance, choosing which employment model to use with this participant, and helping them develop a plan that will get them employed. Finally, with the internship, what we have is we put the student in a real setting and have them act as a professional and supervise their clinical judgments as they do that. This is consistent with what rehabilitation education really wants to pursue. We are looking for people who are consumers of research, who understand research not necessarily to be researchers, but to formulate decision models that are based on research, yet attentive to the situation in which they are serving consumers. So our goal is to prepare students to become informed consumers of research, counselors who know how to read research and figure out how to apply what they learn to their everyday practice. From this, we expect our graduates and their participants to make the best informed choices possible in their rich practice settings. What we need is more research on optimal decision models to improve the quality of the choices they make. We know what we have for best practices, for evidence-based practices, but we do not have an idea of how best to support the everyday decisions of counselors and their supervisors working with specific participants in specific settings. our hope is that the evidence-based practices will continue to advance, but we will do more research in terms of involving specific counselors and participants in the research so that we have more of a participant action research design so that the decision models we teach our students are reflective of sound practice based on what is being done in the field and in the research. So basically that is the way I would summarize what we're doing in rehab education.
Okay, well, thank you very much, Bob. I appreciate that. Our next and last presenter today is Mr. John Connolly, and he will begin by commenting on discussion point 6 from a different perspective. John?
Well, thank you, Joanne, and good afternoon. My name is John Connolly, and I'm with the Council of State Administrators of Vocational Rehabilitation, and also worked for almost 29 years in the Ohio Rehabilitation Services Commission, where I had the opportunity to work on policy development, budgets, consumer appeals, and also the last years that I was with the agency, the overall administration of the agency responsible for production and achievement of the mission. During that time and still today, I've had the opportunity to work with a number of very dedicated vocational rehabilitation counselors. So what I want to share this afternoon comes from that experience and are really my personal views and not those of CSAVR. And as Joanne said, I've been asked to address point 6 with Bob and then point 7 and 8. In regard to point 6, are there approaches in rehabilitation education or service delivery where tools are used that are similar to the description of practice guidelines provided earlier in this discussion? I would say absolutely. And earlier in the discussion this afternoon, Tamara had a list of how practice guidelines are used in the medical field and rehabilitation medicine. And I think that most, if not all, the items on that list are applicable to vocational rehabilitation. As was mentioned in the introduction, vocational rehabilitation, like many other fields today with the challenging economy, is facing increasing challenges as resources get tighter, and yet the demand for outcomes and the quality of the outcomes continues to stay high, if not increase. Generally, in vocational rehabilitation, there are guidelines for VR agency staff, also for consumers, vendors, and referral sources. And going back to tomorrow's list, one of the points on that was to provide a more rational basis for referral. So again, I think that speaks to this point. Also, drivers of these guidelines include the Rehabilitation Act and its accompanying regulations, other federal laws that place requirements on vocational rehabilitation agencies, such as the voter law, state laws, especially those that concern purchasing procedures, professional certification requirements, and Bob mentioned CORE. There's also CRC. There are state licensure requirements that counselors need to meet. Governing bodies. Many vocational rehabilitation agencies are under umbrella agencies within their states, and those umbrella agencies have policies and procedures and guidelines and requirements. And then day-to-day service delivery issues which arise, and of course research findings. And again, going back to tomorrow's list, I think these things speak to making sure that there is not an inappropriate variation in practices, promoting efficient use of resources, quality control, and so on. And of course, agencies strive to have guidelines for compliance and best practices, again, with the drivers that I mentioned in the second point on this slide. Moving to the next point, point 7, are there aspects of vocational rehabilitation service delivery that are more suitable to research-driven practice guidelines? Absolutely. I think that guidelines that are used in the medical field, as we've heard earlier this afternoon, ensure critical steps in a process are not overlooked and are there to improve patient care and results. I think the same thing speaks to the use of guidelines in vocational rehabilitation. They're there to ensure the critical steps in the process are not overlooked and also ensure the best results for the consumers or customers coming to vocational rehabilitation agencies for services. Also, again, as mentioned in the previous point, they're there to ensure compliance with key parts of the vocational rehabilitation process, compliance with the Rehabilitation Act, and again, to look for better ways and ensure better services and outcomes for our customers. One of the first bullets here on this slide is less is better. And I think one of the challenges that I've seen over the years is the issue of how much guidance and policy is needed. VR counselors are professionals, and one message that I have heard repeatedly from counselors over the years is tell me what I need to know to do my job and let me do my job. And I think as we look at guidelines, we have to be very careful to not add guidelines because of a single or limited personnel issue and ensure the guidelines are there to improve the process rather than add burden to the process. So that's why I say that I think less is better. Certainly, again, we need guidelines for compliance, and there are certain key points in the vocational rehabilitation process, and they include eligibility, the development and finalization of the Individualized Plan for Employment, the IPE, and closure, and throughout that whole process, the informed choice, working with the consumer to make sure that the consumer understands their options and can make good choices and has the information available to make those choices. Also, guidelines for purchasing. Vocational rehabilitation counselors have a great responsibility. They are often asked to buy and provide very costly services for consumers that consumers need to achieve their vocational goal. And again, there are limited resources. So counselors and consumers really need to be selective and make good choices and efficiently manage those resources and also manage the vendors and service providers that they work with to get those services. And another area where guidelines are certainly very helpful and are used in vocational rehabilitation are guidelines for serving certain customer populations. Many counselors have what I would call a general caseload. They serve a wide variety of disability consumers. Often those consumers have multiple disabilities and they need to understand the variations and understand the challenges that different disability groups may present as customers and best practices for meeting those needs. In addition to the guidelines for VR agency staff, I certainly think that there are other stakeholders in the vocational rehabilitation system who would benefit from guidelines. In addition to counselors, guidelines for consumers to help empower their participation in the vocational rehabilitation process. I think that the more that a consumer can do in terms of helping with the process, making sure that they have the information that the counselor needs to work with them to determine eligibility, develop the plan, also work to select a vendor, and then when we're looking at placement, for example, doing some of their own job research, understanding job interviewing techniques. Those are all things that, again, empower the consumer and make the process, I think, more meaningful for the consumer, and also make the process more efficient and more quickly leading to a job for the consumer. Guidelines for vendors. Vendors such as community rehabilitation programs are an important part of the vocational rehabilitation system in many states. And one example is guidelines for billing procedures. Different states have different billing procedures, and of course, the more that vendors understand those procedures and follow those procedures, then the more quickly the vendors get payment, and the more efficient the budget management can be. Guidelines for other systems. Other human service systems refer consumers to vocational rehabilitation. For example, the mental health system refers consumers, and the more those other systems understand what kind of information vocational rehabilitation counselors need to make an eligibility determination, and more importantly, probably develop the individual plan for employment, then and provide that information at referral, then the more quickly that consumer, that customer is going to be able to move through the vocational rehabilitation process and move into competitive employment. This brings me to my last point, point 8. How could practice guidelines be useful to both counselors and VR consumers in the development of an IPE or in navigating the issue of informed choice? Well, as I've already talked a little bit about this, certainly I think that guidelines can be very helpful to consumers, and information needed to, again, determine eligibility and develop the individual plan for employment. If the consumer understands what kind of information is needed and is able to gather that data as much as possible, and bring that data to their meeting with the counselor, even their first meeting. Sometimes the counselor can work with that consumer to make that eligibility determination then, and possibly even work through the plan at that meeting and develop the plan with the consumer. So again, the more the consumer understands and is able to provide and gather that information, the more efficiently and more quickly that consumer is going to be served. Researching the labor market. At the core of the individual plan for employment is the vocational goal. What does that consumer want to achieve in terms of competitive employment? What are their interests, abilities, and so forth? But that has to be coupled with a realistic understanding of what's available in the labor market, especially in their area, what are the qualifications that our employers are looking for those jobs, and so forth. So guidelines for a consumer to do some of their own research in regard to the labor market, maybe test some of the things that they would like to do as to whether that's really feasible in that labor market, whether their understanding of the qualifications is the same, then again, that can be very helpful when the consumer sits down with the counselor to work on that part of their plan. Identifying and selecting a vendor. Again, we've talked about community rehab programs today. Often they are a key source of service delivery, working with the counselor and consumer to deliver needed services under the plan to reach their vocational goal. And it's very important that the consumer under informed choice be a part of that selection and also have good information on which to base their decision in working with the counselor to select a vendor. So having guidelines such as what kind of research questions a consumer might want to ask, if they have options as to vendors to help them in working with the counselor to make that decision. Again, the process can go more quickly. Also, the consumer has greater buy-in, and it continues to empower the consumer to help them be independent. And all of those things feed into the development of the individual plan for employment, the IPE. Also, in terms of counselors, how practice guidelines can be useful, we've kind of touched on many of these points, making sure that they comply with the legal requirements that are in the Act and regulations, especially in regard to eligibility, the development of the plan, and informed choice. Bob touched on this. One example of where guidelines have been very helpful are around motivational interviewing, so effective interviewing techniques. And then again, I would just repeat the issue of less is more, and again, I think counselors are always asking, tell me what I need to do in the way of guidance to do my job, and let me have as much time as possible to work and counsel with the consumer as opposed to doing administrative detail. Certainly new counselors coming into agencies, our counseling education programs do a wonderful job, and just as in most industries, you have to make that transition from theory to practice. So guidelines to help those new counselors, for example, with purchasing procedures that a state may have and understanding those, and we've talked about that a little bit. Good data on vendor performance and availability. And of course, this is important in terms of working with the consumer to make that informed choice about what vendor to select to provide needed services under the consumer's plan, and also for the efficient use and management of resources. Some agencies, counselors have their own budget from which to purchase those resources and have to manage it. In other agencies, that's managed more from the central office or headquarters. But overlaying that all is the more efficiently those resources can be used, and the more consumers who can be served, and the more consumers who can be assisted into competitive employment. Pertinent purchasing guidelines, including approval requirements. Again, this goes to the efficiency of the use of resources, and having guidelines to assist in using those resources as most efficiently as possible. And all of these go to the issue of ensuring that critical steps in the vocational rehabilitation process are addressed. So with that, I will turn it back to you, Joanne, and thank you.
Thank you very much, John. We now have a couple of final discussion questions that we'd like to touch on. Next point is 9. Is there sufficient research in VR service delivery to yield evidence upon which practice guidelines can be built? If so, in what areas of research or service delivery? And if not, what research would need to be conducted? Would any of our presenters like to respond to that point?
You know, I think one area, and it's noted here on the slide, is the fact that vocational rehabilitation has recognized that in addition to the consumer with the disability, the other key customer in the process is business. And I think that this is a field or an opportunity where there could be more research done to help in developing guidelines that would be valuable to business in terms of increasing their understanding of and ability to access and use vocational rehabilitation services. So that would, I think, be one area.
Okay, thank you. Tamara, Bob, would either of you like to comment?
I'm going to come at it from this angle. I think there's a lot of research out there that could be brought into the decision-making process. For example, we have a tremendous amount of information coming out of the Bureau of Labor Statistics and state labor market information groups that can tell us what businesses are doing sector by sector, what businesses offer chances for promotion and career advancement, what sectors are declining, what are advancing. And so here I think what would be useful is to take existing things like that, data sources like that, and find ways to systematically introduce them into the IPE process. Not just for the counselor to know, but accessible to the participants. So participants can really find ways to make more what we want them to do in terms of informed choice. So there, you know, we have research, we have wonderful data, but we don't have that last connection between what we know and how we can use it in practice.
Okay, thank you very much. We'll move on to point 10. And our last discussion point for today is, should practice guidelines be developed for VR service delivery, and who should be involved? What stakeholders need to be at the table? Are there priority areas where development of practice guidelines should begin? So let's see who would like to respond first to this final discussion point.
This is Tamara. I'll start. Essentially, what I spoke about at the beginning of this webinar is that all stakeholders do need to be involved. So it is, and the list here is certainly not necessarily completely comprehensive, but depending on the actual practice guideline and at what point in the VR process it is being developed for, you would need to specifically involve everybody who is going to touch the VR system at that point in order to develop an effective guideline, as well as a guideline that will be accepted and used by everybody who is involved. I wanted to bring up one point about the critical points in the VR process, and this is a question for my other presenters. In terms of, I was wondering about whether you felt that there would be a need for a practice guideline for companies so that they're aware of what the process is if someone comes in through a VR process.
John or Robert, can you respond to that?
Well, we've been looking at the employer side of this since about '93, and the minute we start putting guidelines in place like that, the people move, the system moves, and the focus becomes on the disability of the applicant rather than the skills of the applicant.
Okay.
So the way we've moved it is more in terms of assessing the culture of the organization and the openness of the culture just to diversity. And the more open they are to diversity, the more they treat diverse employees and customers well, the better the placement they have. So we've ended up with a methodology that's more about employer development and how to identify the best places for participants to work rather than providing guidelines. If we come in and say this is about disability, they're going to get their lawyers involved, and it becomes problematic quite often.
Well, this is John, and in addition to what Bob has said, again, I think within the vocational rehabilitation field, there's been the understanding that business is the other customer. Agencies, for example, have developed staff to directly serve that customer base. Also, my organization, the Council of State Administrators of Vocational Rehabilitation, has developed a national network recognizing that business today is not just in one local area or state, it's national and international. And I think for business to have information about the services that VR can offer to help them maintain valuable employees in our aging workforce, we develop disabilities, we can still be productive, and also understanding the value. There are more and more studies showing the value of employees with disabilities and how much they bring to the work environment, not just from their own personal contributions and productions, but the very positive impact they have on their coworkers and the rest of the workforce.
Thank you. Does anyone else have another comment on point 10?
Well, I guess I'd build a little bit on what John said. I think if we step back and look at the areas of disability management, occupational health and hygiene, and so on, there are practice guidelines for retaining workers. That would be useful. I think they would be interested in, now the interest is in wisdom workers and in keeping the workers as they get older and develop disabilities. So if we're going to start introducing strategies into business, it may be through that avenue. Again, an area where VR personnel have skills and competence to go out and be consultants.
And this is John. I think another area here are vendors, especially community rehabilitation programs. They offer wonderful services to VR agencies and counselors and consumers. Many of them have resources. Others are non-for-profits and don't always have the resources to provide development and training for their staff. Sometimes they have turnover where they work with a person, for example, maybe a placement person, to get that person to a high peak of production, and then someone hires them away, and then they need to bring in somebody else and get that person up to snuff. So having guidelines in that arena for those entities that maybe don't have the resources or as much resources as they would like to have that development, be able to bring staff along quicker. That might be another area I think that would be right for the development of practice guidelines and see a welcome audience or market.
Well, thank you very much. We're getting ready to run out of time here, so I want to thank you all for a very interesting and thought-provoking discussion. And I'd like to ask each of our presenters if they might have any final comments. Tamara?
No, just thank you for putting this webinar together. It's a very important topic, and I think it's very timely in terms of practice guidelines and how rehabilitation is moving. You know, practice guidelines started from the medical perspective for the immediate care of the individual, then moved into the rehabilitation and into the community, and now we're poised and able to start looking at vocational rehab and where guidelines may be appropriate.
Thank you. Bob, do you have any final comments?
I think as a rehab educator, the more we learn from Tamara and John's perspectives, the more we can integrate it into the pre-service education, and the better able we'll be to graduate students who will go out and do a better job for John.
Okay, thank you. And John, do you have any final comments?
Well, thank you, Joanne. I want to thank my fellow presenters. I really appreciate their thoughts in stimulating the discussion and their contributions. And I think this webinar represents the balance that we have to have from the education perspective, the service delivery perspective, and also the research perspective, and understanding that other disciplines and fields, how much we can learn from them. So thank you.
Well, thank you again very much, and I want to thank everyone for participating in today's webcast. We hope that you found this session to be informative, and I want to remind listeners that today's event was the first in a series of webcasts on knowledge translation from rehabilitation research to service delivery. Also, we intend that these webcasts will foster the creation of a community of practice where this dialogue among researchers, educators, practitioners, consumers, policymakers, and other stakeholders can continue to inform and serve those dedicated to vocational rehabilitation and its goals. Cindy, do you have any last words?
Thanks, Joanne, for your moderation of this webcast. To stimulate more discussion, we invite listeners to contact us to provide your input on today's webcast, share your thoughts on future webcast topics, and participate in the community of practice to continue the dialogue. We'd like to hear from you because your views can inform and shape our future work. You can contact us at the email address shown on the screen, ktdrr@sedl.org. Thanks all.
Thank you, Cindy. We also have a brief online evaluation form and would appreciate your input about the webcast. The link is here on the last page of the PowerPoint file. Everyone who registered will also get an email with a link to the evaluation form. Cindy, let me thank you and your colleagues at AIR from all of the staff here at the KTDRR. We also appreciate the support from NIDR to carry out the webcast and other activities. On this final note, I'd like to conclude the webcast. We look forward to your participation in our next event.